Median nerve injuries can occur at various levels along its course, from the brachial plexus to the wrist. Each level presents distinct clinical features due to the specific muscles and sensory areas innervated by the median nerve. Here's an overview. HAST 1. Injury at the level of the elbow or above. Clinical features: motor loss, loss of flexion of the radial half of the wrist, flexor carpi radialis, weakness or loss of forearm pronation, pronator teres and pronator quadratus, loss of flexion of the thumb and index middle fingers, flexor pollicis longus, flexor digitorum superficialis, and radial half of flexor digitorum profundus, loss of thumb opposition and abduction, thenar muscles via the recurrent branch. Hand of benediction when attempting to make a fist, inability to flex the thumb, index, and middle fingers. Sensory loss: numbness and tingling in the palmar surface of the thumb, index, middle, and radial half of the ring fingers. Management: non-surgical, splinting to maintain thumb opposition and prevent deformities. Physical therapy to strengthen residual muscles. Surgical: nerve repair, grafting or transfer depending on the severity and timing. Tendon transfers, e.g. using the extensor indicis proprius for thumb opposition. 2. Injury at the forearm, anterior interosseous syndrome. Clinical features: motor loss, weakness or paralysis of flexor pollicis longus, flexor digitorum profundus, index and middle fingers, and pronator quadratus. Inability to form an OK sign due to weak flexion at the distal interphalangeal joint of the thumb and index finger. Sensory loss: none, as the anterior interosseous nerve is a pure motor branch. Management: non-surgical, rest and splinting, especially in cases of compression or neuritis. Surgical, decompression or repair if there is structural damage. 3. Injury at the wrist, carpal tunnel syndrome. Clinical features: motor loss, weakness of thenar muscles, abductor pollicis brevis, opponens pollicis, and superficial head of flexor pollicis brevis. Difficulty with thumb opposition and fine motor tasks. Sensory loss: numbness, tingling, or pain in the palmar surface of the thumb, index, middle, and radial half of the ring fingers. Worsened symptoms at night, nocturnal paresthesias. Special signs: positive tinal sign, tingling on percussion of the carpal tunnel. Positive Phalen's test, symptoms reproduced with wrist flexion. Management: non-surgical, wrist splinting in neutral position. Non-steroidal anti-inflammatory drugs, NSAIDs, or corticosteroid injections. Surgical, carpal tunnel release for severe or refractory cases. ASH 4. Injury at the palm, recurrent motor branch, or digital nerves. Clinical features: motor loss, isolated weakness of thenar muscles, especially the abductor pollicis brevis and opponens pollicis. Preserved sensation if only the recurrent motor branch is involved. Sensory loss: if digital branches are involved, numbness in specific fingers. Management: non-surgical, protection of the hand and physical therapy. Surgical, repair of injured branches if possible. General principles of management: initial care, assess for concurrent injuries, vascular or skeletal, immobilization and protection of the injured area. Rehabilitation, range of motion exercises, splinting to prevent deformities and improve function. Follow-up, serial nerve conduction studies to monitor recovery, address complications like contractures or chronic pain. Timely diagnosis and appropriate management can significantly improve outcomes in median nerve injuries.